IVIG demonstration program for an additional 3 years until 2020 to increase patient education and appropriate utilization of infusion services for primary immune deficiencies disease. Mr. Teaberry and Mr. Pascrell's bill, H.R. 3163, that creates a temporary transitional Medicare payment for home infusion services to expand access and help close the gap between changes to the way Medicare pays for infusion services beginning in 2017, and the permanent new home infusion benefit for education and services enacted as part of the 21st Century Cures Act, which takes effect in 2021. Mr. Bishop and Mr. Thompson's bill, H.R. 3172, would help resolve the delay in payment for prosthetics by allowing additional information provided by prosthetists and orthotists, prosthetists.
Feel free, you're going a little bit fast, so like, just put a marker on this one before you start this one, then just slow your words down for this paragraph. Just like that paragraph, slow yourself down because those are tough. You don't want to say prostitutes.
I do not. Okay. I'll
slow that one down. Okay.
Mr. Bishop and Mr. Thompson's bill, H.R. 3172, that would help resolve the delay in payments for prosthetics by allowing additional information provided by prosthetists and orthotists. Orthotists? Sounds so weird. Okay. And other providers.
Or say prosthetists and orthotic providers. But like I think if you just say prosthetists and other providers, you'll be fine.
Okay. And other providers.
Resolve potential delays. Or else Sarah's going to read.
Okay. Mr. Bishop and Mr. Thompson's bill, H.R. 3172, that would help resolve potential delays in payment for prosthetics by allowing additional information provided by prosthetists and other providers who evaluate and fit the beneficiary for the orthotics and prosthetics to be considered by Medicare to support physician documentation of medical necessity for such items. Ms. Black and Ms. Delbenny, Mr. Thompson and Mr. Meehan's bill, H.R. 3164, which allows telehealth technologies to monitor patients receiving dialysis in their home. Ms. Jenkins and Mr. Lewis's bill, H.R. 3166, that helps resolve end-stage renal disease patient access issues by expediting accreditation of dialysis facilities for Medicare billing purposes, by allowing private organizations approved by Medicare to accredit new facilities, and Mr. Marchant and Mr. Kine's bill, H.R. 3173, that provides certainty to providers by codifying recent Centers for Medicare and Medicaid Services Stark Law regulations, clarifying technical violations, including when leases are in violation and when signatures are required.
Procedures around technical violations.
How about procedures related to? Mr. Marchant, Mr. Kine's bill, H.R. 3173, that provides certainty to providers by codifying recent Centers for Medicare and Medicaid Services Stark Law regulations, clarifying procedures related to technical violations, including when leases are in violation and when signatures are required. Finally, this legislation is offset using funds from the Medicare Improvement Fund. As noted on the green sheet, the chairman's amendment would modify Section 302 of the bill to specify a dollar amount to be used from the Medicare Improvement Fund in order to offset the legislation in a budget-neutral manner. Mr. Chairman, that completes my walkthrough, and I'm happy to answer any questions. Oh, it's just what you sent me. Oh, you didn't? Oh. Okay, I'm sorry. Okay. No, you're fine. Yep. Yeah. What's going on? You're good. That's right. That's right. Pretty exciting. I get to do this. It's not fun.
Mic check, 1, 2, mic check. Mic check, 1, 2.
You even want to say it.
This is Emily. Mic check. It works. 1, 2, 3, 4, 5. This is Emily. Mic check. 1, 2, 3, 4. Mic check. 1, 2, 3, 4.
Looks like we're just like sort of updating the definition. It's very similar.
Mic check. 1, 2, 3, 4. Mic check. Hey, what's going on, Tom? Mic check. 1, 2, 3, 4, 5, 6. Mic check. Can you hear me now? This is why you should change to Sprint. Good.
Life-threatening or significantly limits overall health function,
That's the difference then.
have a high risk of hospitalization
That's in there.
or other adverse health outcomes,
It's in there.
and require intensive care coordination.
That's the difference.
And that is listed under basically the panel and what is created by the panel.
Okay. Well, if needed, we'll pull that. That's helpful. And you can have a copy for you so you can also. Okay. Nick, is it okay if let's just do this in my office? We'll go through the questions. Hey. Yeah.
Check, check. 1, 2, testing. Screen's good over there, that small one as well. Testing, testing. Ready? Testing, 1, 2, 3, testing, testing. I can speak louder. Testing, 1, 2, 3. One more. Of course. Check, check, testing, 1, 2, 3. Testing, 1, 2, 3, check, check.
Mic check, 1, 2, mic check. Check, mic check, 1, 2, check, mic check.
Mic check, check for the court reporter. Testing the audio for the court reporter. Testing, 1, 2, 3, testing, 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 1, 2, 3. Testing for the court reporter. Testing, 1, 2, 3, testing.
Check, check. Sorry. Check, check. Testing, testing, check, 1, 2. Testing, testing.
The committee will come to order. Today, our committee has moved forward on several major priorities for the American people. We'll consider 3 bipartisan bills, 2 focused on improving Medicare for America's seniors, and 1 that strengthens IRS accountability for hardworking taxpayers. We'll start with our 2 health care bills. First up is H.R. 3178, bipartisan legislation that I've introduced with Ranking Member Neal that makes targeted immediate improvements to the Medicare Part B program. Improving and strengthening Medicare for the long term is a significant priority for our committee, but our work toward that larger goal shouldn't stop us from delivering smart, focused reforms that help beneficiaries today. That's exactly what H.R. 3178 will do. As a sponsor of this bill, I'll be providing a more detailed description shortly. Our second bill today is H.R. 3168, legislation sponsored by Congressman T. Berry and Levin, the chairman and ranking member of our Health Subcommittee. This bill reauthorizes Medicare special needs plans and takes actions to improve the quality of care for all the Americans who rely on them. Today, over 2 million Medicare beneficiaries are enrolled in special needs plans. These are some of our nation's most vulnerable patients, including elderly Americans who live in poverty or have a chronic illness. This bill, by Congressman T. Berry and Levin, will extend special needs plans and help strengthen them for years to come. This bill provides certainty for Medicare beneficiaries, increases efficiency through greater care coordination, and improves access to high-quality care for Americans who depend on special needs plans. Our final bill today is H.R. 1843, the Clyde Hirsch Sowers Respect Act, sponsored by Congressman Roscom and Crowley. This bill takes actions to protect taxpayer rights by placing strong checks on the IRS's civil asset forfeiture authority. Back in 2015, our Oversight Committee, then led by Mr. Roscom, began investigating reports that the IRS was using its civil asset forfeiture authority to illegally seize the bank accounts of law-abiding small business owners. As our investigation confirmed, this authority, which is meant to crack down on criminal enterprises, terrorist networks, and drug dealers, was instead being used by the IRS to go after honest taxpayers. And this was done on multiple occasions. Farmers and family-owned businesses had their bank accounts frozen and their assets seized. Main Street job creators were driven to the edge of bankruptcy. All of this simply because the IRS thought their bank deposits looked suspicious. In the end, despite the fact that these hardworking Americans committed no crime, the IRS still forced them to forfeit hundreds of thousands of dollars, or thousands of dollars, to the government, money they needed to sustain their businesses, pay their workers, and put food on the table for their families. Randy Sowers, a dairy farmer and one of the people Mr. Roskin's bill is named after, said it best when he testified before the Oversight Subcommittee then. Mr. Sowers said, "I thought the government was supposed to protect me. I didn't think they were supposed to come out and try to put me out of business." And that's why the Clyde Hirsch Sowers Respect Act is so important, puts in place strong safeguards that will truly protect taxpayers from IRS abuse. And under this bill, the IRS will no longer be able to use civil asset forfeiture authority to seize the funds of innocent Americans without warning, without probable cause, and without due process. Instead, there'll finally be real transparency and accountability for taxpayers. Last Congress, this legislation passed the House unanimously. It's proof that no matter which side of the dais you sit on, we can all agree on the need to protect taxpayers from this kind of abuse by the IRS. I hope that this bill and all the bills before us today will receive the bipartisan support they deserve. I want to thank all the members on both sides of the aisle who've worked so hard to develop these important solutions. This time, I recognize the ranking member for any opening comments he may have.
Thank you, Mr. Chairman, for holding this bipartisan markup today, and I hope that we hold more meetings just like this. This is what the American people want and expect from their members, to get things done in a bipartisan manner. I am pleased that you and I were able to work together to develop these common sense bills to improve Medicare and the rules governing civil asset forfeiture proceedings. The first bill we'll consider today is Medicare Part B Improvement, a collection of bipartisan, low or no-cost Medicare Part B policies recently introduced in the House. Chairman Brady and I, Health Subcommittee members Mr. T. Berry and Mr. Levin, are original co-sponsors of the overarching measure, and I certainly encourage our colleagues to support it. Specifically, the bill includes a common-sense transition policy for home infusion services led by Mr. T. Berry and Mr. Pasquale to help ensure access to home infusion for Medicare beneficiaries. It also includes a measure co-sponsored by our colleagues Mr. Bishop and Mr. Thompson to streamline Medicare rules to improve access to medically necessary prosthetics and orthotics. Mr. Lewis is the leader on the language to address accreditation process backlogs for dialysis facilities that treat end-stage renal disease. And our colleagues, Ms. Del Bene and Mr. Thompson, are co-sponsors of a bill to allow telehealth for patients who receive dialysis at home. The measure also includes clarification language to the Stark laws that Mr. Kine led to provide more certainty for Medicare providers. The second health bill we will consider today is H.R. 3168, introduced by Mr. Teaberry and Mr. Levin to modify and extend the Medicare Special Needs Plans, or SNPs, or SNPs. This bill makes a few minor policy changes consistent with recommendations from MedPAC. While not all our members have SNPs operating in their districts, we all understand and recognize their importance. I'm certainly happy to have a number of SNPs that reside in or serve residents in my district. The third bill we'll consider today is oversight legislation sponsored by Mr. Crowley and Mr. Roscom that, again, we acknowledge has passed the House in the past unanimously. The proposal ties back to the Bank Secrecy Act, which was set up to report obligations for certain activities, such as depositing more than $10,000 in cash. Unfortunately, some taxpayers engaged in legal activities got tangled in these proceedings because they were frequently depositing cash sales as part of their normal, legitimate business plan. Until 2014, the IRS took a hard line and pursued civil asset forfeiture against taxpayers when the money used for structured deposits was acquired legally or illegally, but they have since stopped this practice. This legislation will codify the present approach and stipulate that any interest paid on returned property is non-taxable. I want to thank and acknowledge all the bill sponsors for their hard work on this legislation. Thank you, Mr. Chairman, for working with me on this markup. I encourage our colleagues to support all of the measures before us today, and I yield back the balance of my time.
Thank you, Mr. Neal. The committee will stand in recess and will reconvene immediately following this vote series.
That's the way to do it. Do you sign commemorative coins? I've got it for the Basketball Hall of Fame.
Oh, yeah. The committee will come back to order. Our first order of business is H.R. 3178, the Medicare Part B Improvement Act of 2017. I recognize myself for an opening statement. I'm honored to present H.R. 3178 for the committee's consideration. This bipartisan bill provides an opportunity to advance targeted, immediate reforms that will make Medicare work better for the American people. As I said at the beginning of today's markup, improving and strengthening Medicare for the long term is a major priority for the committee. But our pursuit of that goal shouldn't keep us from taking action to help beneficiaries today, and that's what H.R. 3178 will do, help millions across our nation. This bill includes solutions crafted by roughly a dozen members of our committee from both sides of the aisle. The bill takes action on three primary goals for improving Medicare Part B. First, expanding access to high-quality care. Secondly, improving efficiency in the delivery of care to better ensure that patients can receive the care they need when they need it. And third, easing Medicare's administrative burden on providers so they can spend less time on paperwork and more time with patients. Importantly, H.R. 3178 extends and improves Medicare home infusion services, which allow patients to receive personalized care in the comfort of their own home. This bill will also extend an ongoing Medicare pilot program, the IVIG demonstration program, that allows patients with weakened immune systems to receive care in their homes. This demonstration program carries a lot of meaning for me because patients with immunodeficiency diseases, especially children, have to fight every day just to survive. Allowing these vulnerable patients to receive treatment from the safety of their own home can not only improve the quality of their care, it can greatly enhance their quality of life. That's why I led the charge with Ms. Matsui and Mr. Kind to create this demonstration program back in 2012. And it's why we need to extend this demonstration now to further evaluate the benefits of increased outreach, education, and payment for IVIG treatments in patients' homes. To that end, I'd like to submit for the record a statement by Ms. Matsui voicing her strong support for extending the IVIG demo. In addition to these important provisions, this bill contains numerous improvements that will increase access to high-quality, coordinated care for beneficiaries. From making dialysis treatments more available for patients, to clarifying and putting into law existing Medicare rules related to technical violations of Stark Law, physician self-referral policies, all of these solutions are building blocks to a more modern Medicare program that better meets the healthcare needs of our constituents. I really want to thank all the members on both sides of the aisle for their hard work and leadership on these solutions. I especially want to thank Ranking Member Neal, along with Health Subcommittee Chairman T-Berry and Ranking Member Levin, for joining me in introducing this important bill to improve Medicare. And I'd also like to recognize Chairman Walden and Ranking Member Pallone of the Energy and Commerce Committee for their leadership and their hard work in helping us move this bill forward. And I'll turn to Mr. Neal for purposes of an opening statement.
Thank you, Mr. Chairman. And again, a sincere thank you for including this bipartisan bill in today's markup. I'm happy that you and I were able to work together in a bipartisan manner to bring together a number of important bills to improve Medicare Part B. As I said in my previous opening remarks statement, that the more we can have meetings like this, the better, because it's what our constituents sent us here to do, to get things done. The bill before us today, the Medicare Part B Improvement Act, is a common-sense bipartisan package of Medicare Part B policies that you and I and our colleagues, Chairman T-Berry and Ranking Member Levin, are original co-sponsors. I encourage all of our colleagues to support this legislation. The bill does a number of things to improve Medicare Part B. It includes a common-sense transitional policy for home infusion services, improves access to medically necessary prosthetics and orthotics, and addresses accreditation process backlogs for dialysis. It also allows telehealth for patients who receive dialysis at home and provides more certainty for Medicare providers by clarifying Stark laws. Thank you, Mr. Chairman, and I encourage our colleagues to support this bill, and I yield back the balance of my time.
Thank you, Mr. Neal. We'll now proceed to consideration of H.R. 3178. Without objection, the measure will be considered as read and open for amendment at any point. This time, I offer an amendment in the nature of substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I'll now turn to Emily Murray, the Staff Director for the Health Subcommittee, to provide the technical description of the amendment in the nature of substitute, with an emphasis on the changes made since introduction. I ask that members hold their questions till after her presentation. Ms. Murray, you're recognized.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 3178, the Bipartisan Medicare Part B Improvement Act of 2017, was introduced by Chairman Brady and Ranking Member Neal, along with Health Subcommittee Chairman Teaberry and Ranking Member Levin, on July 11, 2017. In general, the legislation makes improvements to the delivery of home infusion therapy and dialysis services, among other provisions. H.R. 3178 contains a number of provisions that have been introduced previously by members of the committee. Chairman Brady, Ms. Matsui, and Mr. Kine's bill, H.R. 3172, that extends an ongoing IVIG demonstration program for an additional 3 years until 2020 to increase patient education and appropriate utilization of infusion services for primary immune deficiency diseases. Mr. Teaberry and Mr. Pascrell's bill, H.R. 3163, that creates a temporary transitional Medicare payment for home infusion services to expand access and help close the gap between changes to the way Medicare pays for infusion services beginning in 2017 and a new permanent home infusion benefit for education and services enacted as part of the 21st Century Cures Act that takes effect in 2021. Mr. Bishop and Mr. Thompson's bill, H.R. 3172, that would help resolve potential delays in payment for prosthetics by allowing additional information provided by prosthetists and other providers who evaluate and fit the beneficiary for orthotics and prosthetics to be considered by Medicare to support physician documentation of medical necessity for such items. Ms. Black, Ms. Dalbeni, Mr. Thompson, and Mr. Meehan's bill, H.R. 3164, which allows telehealth technologies to monitor patients receiving dialysis in their home. Ms. Jenkins and Mr. Lewis's bill, H.R. 3166, that helps resolve end-stage renal disease patients' access issues by expanding accreditation of dialysis facilities for Medicare billing purposes by allowing private organizations approved by Medicare to accredit new facilities. And Mr. Marchant and Mr. Kine's bill, H.R. 3173, that provides certainty to providers by codifying recent Centers for Medicare and Medicaid Services Stark Law regulations, clarifying procedures related to technical violations, including when leases are in violation and when signatures are required. Finally, this legislation is offset using funds from the Medicare Improvement Fund. As noted on the green sheet, the Chairman's amendment would modify Section 302 of the bill to specify the dollar amount to be used from the Medicare Improvement Fund to offset the legislation in a budget-neutral manner. Mr. Chairman, that completes my walkthrough. I'm happy to answer any questions.
Thank you. Are there any questions about the amendment in the nature of a substitute?
Mr. Chairman.
Mr. Doggett, you're recognized.
So as I understand it, Ms. Murray, you've got 3 or 4 very diverse parts of Medicare, a demonstration project, dialysis, and Stark Law, but they have their common nexus in this bill that they're all part of Medicare Part B improvements.
That is correct.
Different parts of Medicare Part B, but joined together in this one consolidated bill. Does this bill grow out of recommendations of MedPAC?
The legislation before us includes various different provisions that have been talked about at various hearings or member priorities. I'd have to get back to you on as to if there are specific policies from the MedPAC report.
But you all have already done a MedPAC hearing, haven't you?
That is correct.
On this year's report, and you do it every year, and I'm sure the staff has read thoroughly their report. Do you also read the reports of the Office of Inspector General concerning the operations of Medicare Part B and the other parts of Medicare?
That is correct.
Are there any parts of this legislation that deal with any of the MedPAC recommendations or the Office of Inspector General recommendations on pharmaceuticals?
Not in the legislation before us.
Not in the legislation. They're excluded. Thank you.
Thank you. Excuse me, are there any other questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Ms. Jenkins, you're recognized.
Thank you, Chairman Brady, for bringing these bills up so quickly for a markup. I appreciate the inclusion of H.R. 3166, the Dialysis Certification Act, in H.R. 3178. I can't overstate the importance of this bill to the dialysis provider community, patients, and overburdened states that contract with the Centers for Medicare and Medicaid Services to survey and certify dialysis clinics. In Kansas, several clinics have been built and still await a survey, or have operated for years and now require a recertification but must wait months or even years for that. And in Kansas, we have clinics waiting more than 600 days for a certification. HR 3166 gives dialysis providers the opportunity to receive surveys and certifications from a CMS-approved third-party accreditor, much like hospitals are able to do now. Those third-party organizations must demonstrate their standards are as good as or better than those standards used by CMS, and the Secretary must approve them. I've worked with the dialysis provider and patient community for months on this bill. I toured a dialysis clinic last year and spoke with the test patient and physician on staff about the care the clinic will provide. However, I was frustrated to learn that the state-of-the-art clinic that will fill a need in Topeka, Kansas for ESRD patients has been waiting 2 years and can't open because it can't obtain certification. It just sits there with its doors closed to the community. All the equipment sitting there, it's new, it's in a great location, and it's ready to serve the community, only it can't. That's not the only clinic waiting for months for a certification. A clinic in Pittsburgh, Kansas, also in my district, has been waiting for 235 days. And without these clinics, patients are forced to go try to find other clinics, sometimes hours away. And that's not right. It seems to be a problem easily solved by HR 3166 throughout the waiting process. They should have been able to seek those certifications from an approved outside group, and HR 3166 will finally allow that. Thank you, Mr. Chairman, for including this bill in today's markup, and thanks to the Energy and Commerce Committee for working with the Ways and Means Committee to allow dialysis clinics across America to more easily obtain a survey so they can serve the patients that depend on their care. With that, Mr. Chairman, I yield back.
Thank you. Mr. Lewis, you're recognized.
Thank you, Mr. Chairman. Mr. Chairman, I would like to strike the last word.
Sir.
Mr. Chairman, I want to thank you for bringing this piece of legislation forward and to express my support for the Medicare Part B Improvement Act. This legislation includes a provision that would improve access to care for Medicare patients with kidney disease. Living with kidney disease is not easy. Every single day is a struggle. Every single day you're in pain. And in many places, it is hard, very hard to access services. For many years, I worked to speak up for those with kidney disease. I believe we have a mission and an obligation to stand up for those who are fighting for their health and livelihood each and every day. For these reasons, I'm proud to work with our colleague, Ms. Jenkins, and thank her very much for her help on this most recent effort. We sponsored the language in this bill that will improve the accreditation process of dialysis clinics and allow them to reach out to our brothers and sisters who are living with ESRD. Again, I thank you, Mr. Chairman, and I encourage all of our colleagues to vote yes on this bill. And I yield back, Mr. Chairman.
Thank you, Mr. Lewis. Mr. Reichert, you're recognized.
Thank you, Mr. Chairman. I support the underlying bill, but as we are considering legislation today to improve both the Medicare program and the beneficiary experience, we cannot and should not forget the 1.5 million Medicare beneficiaries suffering from lymphedema around the country who need our help. 68% of lymphedema cases are cancer-related, however, 22% are non-cancer related, about 10% are primary forms, which can be attributed to another 40 different diseases. Whatever the underlying cause, lymphedema occurs when the lymphatic system is compromised, causing painful and debilitating swelling. Fortunately, there is effective treatment available to help seniors with suffering from lymphedema, notably it's compression therapy. The strange part about this, though, is that Medicare provides guidance to these patients to use compression garments before the use of pneumatic pumps. Now, Medicare covers pneumatic pumps, but they don't cover the garments, which they include in their definition of proper treatment for lymphedema. Mr. Blumenauer and I have legislation to close this coverage gap, H.R. 930, the Lymphedema Treatment Act, which enjoys support from over 260 co-sponsors. So, Mr. Chairman, it's long past due that we fix this. It's a small common sense improvement to Medicare. It will have an enormous positive impact on the health of millions of seniors and reduce costs to our healthcare system. So I look forward to working with you, Mr. Chairman, and with Secretary Price to close this coverage gap and finally provide our seniors with access to compression garments for effective treatment of lymphedema. I yield back.
Great. And Mr. Reichert, thanks for your leadership there. Let's continue to work forward for a solution. Thank you. Mr. Pascal, you're recognized.
Yeah, thanks, Mr. Chairman. I move to strike the last word.
Yes,
I want to
sir.
thank you for holding the markup today. I'm pleased that the bill before us today includes legislation that I introduced with my good friend, Congressman Pat Tiberi, the Medicare Part B Home Infusion Services Temporary Transitional Payment Act. The 21st Century Cures Act, which became law last year, correctly adjusted payments for home infusion drugs and would establish a new home infusion nursing benefit within Medicare beginning in 2021. However, we have heard concerns that the payment adjustment going into effect before the nursing benefit is implemented could jeopardize access to home infusion in the interim. So the bill Congressman Tiberi and I introduced would address that concern by creating a temporary nursing benefit until the new permanent benefit can be implemented. So I urge my colleagues to support this legislation, and I thank you, and I yield back, Mr. Chairman.
Thank you, Mr. Pascal. Mr. Bishop, you're recognized. Strike the last word.
Thank you, Mr. Chairman, for holding this markup today, and thank you for your leadership in introducing the bipartisan Medicare Part B Improvement Act. I'd also like to thank Ranking Member Neal, Congressman Tiberi, and Congressman Levin for working with me, Congressman G.T. Thompson, and our Democrat colleague Mike Thompson to include a provision in which the bill that would streamline rules and make common sense changes in order to preserve access to orthotics and prosthetics for patients in need. In particular, our initiative would allow additional information provided by prosthetists and orthotists, the trained clinical experts who evaluate and fit the beneficiary, to be considered by Medicare to support documentation of medical necessity for orthotics and prosthetics. This is extremely important. Under current law, Medicare pays for orthotics and prosthetics for beneficiaries who medically need these items. Some suppliers, however, are experiencing a severe delay, up to 5 years in fact, in payment for prosthetics, simply because CMS and their contractors do not provide fair consideration of the necessary documentation. The insufficient support bureaucrats give to these providers severely weakens the bond between orthotists and prosthetists and the beneficiary. For instance, the relationship between an amputee and their provider is a major factor in the quality of life, and is often a bond that has developed over years, even decades. Oftentimes, a patient seeks out their orthotic and prosthetic provider when they have issues or questions, rather than a referring physician, as is the prosthetist or the orthotist, as it is the prosthetist or the orthotist that is the only clinician qualified to make the determination of what type of prosthetic or orthotic will best enhance their quality of life. This straightforward bipartisan provision will not only improve the quality of life of the beneficiary, it will also save jobs of orthotic and prosthetic suppliers, many of whom are severely impacted by the lack of payment being tied up for years by Medicare. I urge my colleagues to join me in supporting the Medicare Part B Improvements Act, and with that, I yield back.
Thank you. I ask unanimous consent to submit for the record a statement by Mr. Marchant in support of the portion of H.R. 3173, Stark Administrative Simplification Act, which he's authored with Mr. Kine, and seeking commitment to continue to work to finish the technical work to move forward as possible with the remainder of the policy outlined in his original bill, which I will be glad to continue to work with him on that. I also ask unanimous consent to submit for the record a number of groups in support of this measure. Ms. Chu, you're recognized to strike the last word.
Well, I would like to thank Congress members Jenkins and Lewis for their efforts to ensure patients with end-stage renal disease have access to dialysis treatment. And I certainly support the provisions in H.R. 3178 that would allow dialysis treatment centers to receive independent accreditation. This change would alleviate the current backlog in the accreditation process and provide relief to dialysis patients who lack access to these centers. Current law requires dialysis treatment centers to be both certified by the state and accredited by Medicare before the center can serve Medicare patients, who make up nearly 85% of all dialysis patients. However, long backlogs in the Medicare accreditation process through CMS are preventing dialysis centers from opening and providing treatments for these patients. In my home state of California, I've seen the wait time for CMS certification increase from approximately 60 days to 12 months in the last year. As the renal disease population increases, the need for dialysis treatment is significantly outpacing the approval process. To meet this demand, existing dialysis treatment centers that are approved to see Medicare patients are extending their hours of operation to provide appointment times very early in the morning or very late at night. This means adding anywhere from 4 to 8 hours of additional operation. Because dialysis treatment takes up to 4 hours, patients are then obligated to travel in the middle of the night in order to meet their appointment times. Furthermore, since many low-income patients use public transportation or have a limited ability to travel longer distances, some may be forced to miss or skip an appointment and wind up in the hospital because they could not access treatment. Right now, there is a dialysis treatment facility in Pasadena, in my district, that is ready to begin operation and has the capacity to serve 200 patients. But this facility has been stuck in the backlog for 18 months. This facility is desperately needed because all neighboring facilities are operating above 90% of their capacity, and some are even scheduled to close later this year. Without this new facility, 200 dialysis patients could be left with no local options to receive treatment. H.R. 3178 contains a provision that would permit dialysis centers like the one in my district to seek certification from independent accreditation organizations approved by Medicare. This is a common sense measure, as many other Medicare providers like hospitals and nursing homes are already permitted to seek accreditation through independent organizations. By opening up other avenues for accreditation, we can bring down the backlog and increase Medicare patients' ability to receive quality dialysis treatment near their home. I support this provision and urge my colleagues to do the same. And I yield back.
Thank you, Ms. Chu. Ms. Black, you are recognized to strike the last word.
Thank you, Mr. Chairman. And I'd like to thank Chairman Brady and Chairman Teaberry for recognizing the importance of including a critical step to expanding access to telehealth in this legislation. I'd also like to thank my partners in this endeavor, Representatives Delbaney, Thompson, and Meehan. Now, for those who are suffering from end-stage renal disease, the ability to receive their dialysis treatment at home with the peace of mind, knowing their doctors are monitoring them remotely, can make all the difference to them. I'm proud to work on legislation that ensures that our seniors have access to the same innovative and cost-effective technology that has long been available to the rest of the country. My bill, H.R. 3164, which is included in the Medicare Part B Improvement Act of 2017, is an important step, but it's just that, it's a step. And I look forward to continuing my work with my colleagues at the Ways and Means Committee and the Energy and Commerce Committee to maintain this momentum and pursue new avenues to expand access to life-giving telehealth services. Thank you again, Mr. Chairman and Chairman Teaberry, and I yield back.
Thank you, Ms. Black. Mr. Thompson, you're recognized. Strike the last word.
Thank you, Mr. Chairman. I, too, want to thank you for having this hearing and echo Mr. Neal's remarks that this type of bipartisan work is something that is important both to the institution of representative government and to the people that we represent, and I hope we can do more of this. In particular, I just want to speak favorably regarding two pieces of the bill that's before us, and I think other members have mentioned them both, but the telehealth portion is incredibly important, not only to those receiving dialysis at home, but this is a huge step
towards what I think needs to be a lot more work in regard to telehealth. We can do a tremendous amount to provide quality health care for folks in underserved areas and save a lot of money in doing it by expanding our efforts in telehealth. And I remember back in the 90s when I carried the first state legislation to allow non-face-to-face reimbursement for telehealth services. It just opened tremendous doors in California, and we have an opportunity to do the same here. And then secondly, the piece regarding orthotics and prosthetics. Again, this is something that's going to save people heartache, it's going to save money, and it's going to be beneficial to a lot of businesses who, because of the way things work right now, sometimes have to wait months and months and months for delayed payments. So this is a real positive step today, and I would encourage passage of the measure, and thanks to all of those on the committee who have worked with me and allowed me to work with you to move these pieces forward. Yield back the balance of my time.
Thank you, Mr. Thompson. Mr. Tiberi, you're recognized.
Thank you, Mr. Chairman, for bringing these bipartisan bills to the Ways and Means Committee today, especially H.R. 3178, which includes my bill along with my friend Bill Pascrell from New Jersey that provides a temporary transitional payment for home infusion providers. The 21st Century Cures Act created a new reimbursement benefit for home infusion therapies beginning in 2021. This new temporary transitional payment will close the gap in care for beneficiaries and home infusion providers will continue to administer these therapies without risk of going bankrupt. I'd like to thank my colleagues on this committee for their support. I'd also like to thank my colleagues on the Energy and Commerce Committee for their commitment to working on the issue, especially my counterpart, Subcommittee Chairman Michael Burgess, Chairman Greg Walden, Chairman Emeritus Fred Upton, who helped pave the way for these policies with the passage of the 21st Century Cure Act. It's important to note that this is not the end for policies encouraging care, especially drug infusion, in the home for patients that choose to do so, and we look forward to working with the administration in clarifying current rules to ensure successfully implementing this and future policies to include these payments for all drugs needed by this home infusion patient community. These bills were brought to the committee in a truly bipartisan fashion. I'd like to thank my healthcare ranking member, Mr. Levin, as well, and urge my colleagues on both sides of the aisle to vote in favor of these bills.
Thank you, Chairman Tiberi. Ms. Sewell, you're recognized to strike the last word.
Thank you, Mr. Chairman. I want to offer my support of H.R. 3178. I want to also acknowledge that I'm a proud co-sponsor of the bill introduced by Representatives Black, Delbene, and Thompson that is included in this underlining bill. This policy modernizes Medicare payment policies for the use of telehealth for ESRD-related visits. My home state of Alabama and the neighboring states of Mississippi and Tennessee are home to the highest rates of kidney disease in the country. I've visited with kidney disease patients in dialysis facilities across my district, from small dialysis clinics in rural towns to the ESRD unit at Children's Hospital in Birmingham. The treatment is taxing for patients and families who have to go to their clinics to receive treatment 3 days a week for 4 hours at a time to simply sustain life. For these patients and their families, this bill will have a significant impact on their quality of life by expanding access to home dialysis therapy. Technology has allowed for the creation of home dialysis devices. Our Medicare dialysis patients deserve access to these advanced technologies. We must modernize our dialysis payment policies to keep apace with the rapid development of innovation so that these Medicare patients are not left behind. I again want to support the underlining bill 3178 and look forward to supporting it today in this committee as well as on the House floor for final passage. I do believe that my constituents, all of our constituents, would be proud of such bipartisan legislation. Thank you, and I yield back the balance of my time.
Thank you, Ms. Sewell. Mr. Blumenauer, you're recognized to strike the last word.
Thank you, Mr. Chairman. It's great to see the movement here, the in-state renal situation in this country. We spend 1% of the federal budget on dialysis, and as several of my colleagues have mentioned, dealing with renal disease just takes over people's lives. while it shortens them and complicates things for the family. Being able to accelerate the accreditation of institutions is positive. Extending the opportunities for telehealth to be able to make it easier on some of the most vulnerable of patients, I think is very, very important. I would hope, I would note that I've been working with my colleague, Mr. Smith, on some legislation to do a better job of helping people in this situation to take advantage of the time and energy that is spent to be able to reduce demands and improve care and maybe even save some money while we're doing it by giving an opportunity to sort of bundle services that are involved. We've got a proposal that would be a demonstration project to test it out, but we've been working with all the stakeholders. In fact, our former colleague, Senator Young, and I spent a year and a half on that in the prior Congress. I hope there's an opportunity to focus on moving forward on some of this. And I would associate myself with the comments of Mr. Reichard. The legislation he referenced, I think we've got like 260 co-sponsors. If it's not teed up and ready to go, it's very close, broad bipartisan support, and it's nice occasionally to have hearings like this where we walk away feeling like we've done a good job, we're making a difference, and we're able to do it in a cooperative basis. Thank you, Mr. Chairman.
Thank you, Mr. Blumenauer, for those points. Mr. Kine, you're recognized.
Thank you, Mr. Chairman. Mr. Chairman, I too want to echo my support for the bipartisan markup with these Medicare Part B programs today. I'm also pleased that we see portions of the Stark Simplification Act that I've introduced with Representative Marchant included in this markup. There are some additional technical fixes that we're hoping to be able to work with you and the committee in order to improve upon before we get it ultimately across the finish line, but this is certainly a good first start. And I'm also happy that we're doing this today because the Medicare trustees just issued the recent report and update. And they're showing that the Medicare Trust Fund solvency has been extended by 1 year, which is good news, to 2029. They also indicated that the IPAB trigger will not be triggered in their estimation until at the earliest 2021. So that gives this committee some time in order to hold some hearings, have discussions about what further steps we can be taking working together in a bipartisan way to constrain the cost of not just the Medicare program, but the entire healthcare system. That, I believe, is what we really ought to be focused on in this Congress, is how do we make healthcare more affordable for all Americans, rather than the dance that we're going through right now, watching the Senate try to cobble together a bill that will leave millions of Americans behind in our healthcare system. I'm also pleased that we're extending to 2020 the current Medicare demonstration for the IVIG program. And I want to commend you and Ms. Matsui in particular for the leadership that you've shown on this important demonstration project, and again, buying some additional time so we can learn more of the work that is doing. So I support the legislation, appreciate the bipartisan effort. 2021, the earliest IPAB, so people can take a deep breath around here again. But our work continues to do everything we can to constrain the cost of health care for all Americans. I yield back. Thank you.
And Mr. Kine, as I mentioned earlier, I look forward to working with you, Mr. March, to finish out the work on the Stark technical. Those are important provisions. Ms. Delbeni, you're recognized. Strike the last word.
Thank you, Mr. Chair. I'd like to thank the chair and ranking member for working with me to include a proposal in this bill that I developed with my colleagues, Representatives Black, Thompson, and Meehan, which would modernize Medicare and harness the promise of telehealth to improve care for patients nationwide, allowing patients with end-stage renal disease to receive dialysis at home can dramatically improve their health outcomes and quality of life. This is something I've heard consistently from providers in my home state of Washington, like the Northwest Kidney Center, who do incredible work to help patients receive dialysis at home when it's medically appropriate. Advances in telehealth hold great potential to extend this treatment option to more Americans, particularly in rural communities, but there are still too many barriers to the use of cutting-edge technologies in Medicare. There's a huge need to update our laws to reflect these innovations and reimburse telehealth appropriately. Otherwise, we won't just be denying access to health care today, we could be preventing the next frontier of innovations from even getting off the ground. Without the long-term visibility of Medicare coverage, startups and entrepreneurs might never get the funding they need to develop their technologies and bring them to market. It's essential that we unlock the full potential of telehealth. By doing so, we can improve patient care, promote health, and defeat heartbreaking diseases and save lives. That's why I'm so glad we're taking this first step today. And as co-chair of the Congressional Kidney Caucus, I'm pleased we're starting this important work by breaking down barriers to home dialysis. So thank you again to the committee for working with me on this important bill, and I hope it's the first of many victories as we work to expand telehealth. Thank you, and I yield back.
Thank you, Ms. Del Benny. Are there any amendments to the amendment in the nature of substitute?
I have an amendment at the desk, Mr. Chairman.
Yes. So, gentlemen, if the gentleman will suspend while the clerk will distribute the amendment. Mr. Nunes?
Mr. Chairman, I reserve a point of order.
Point of order has been reserved. The clerk will distribute the amendment. I ask the gentleman to suspend while the clerk distributes. Thank you. Gentleman from Texas recognized for 5 minutes.
Thank you very much, Mr. Chairman. As has been explained, this bill is a package of 6 separate bills. All of them seem worthy, most modest in their scope. One simply codifies, puts into law what is already agency practice. Another extends by a few years a demonstration project which appears to be working and on which we need further insight. I have no problem with any of the 6 separate measures that deal with different parts of Part B. I do find it ironic, in no way disparaging the efforts of all those that have commented, that this bill is being taken up on the day that we see the next sequel in the trilogy of healthcare measures, this one over in the Senate, which will, of course, do far more harm to far more people than anything we're able to do here today through this piece of legislation. I do think that there is one glaring omission. As proposed, this bill, while it deals with Part B, does not address any aspect of the ever-rising cost of Part B medications. Since last September, I've sought hearings across the board on soaring prescription prices in this committee. I think that they threaten families and they burden most any type of taxpayer-financed healthcare initiative. And I've raised this troubling issue at a number of our related hearings and markups going back well into the beginning of last year, joined on several occasions by a number of our Democratic colleagues who are concerned about the exploitation of government-approved monopolies that can and do result in monopoly prices. There have been few opportunities that have been permitted within this committee to address this challenge, and none of these permit the offering of comprehensive solutions. But today, we can take a very modest step to just ensure that we have the prices that are being charged for Part B pharmaceuticals. Under longstanding existing law, pharmaceutical companies are required to provide average sales price data on Part B Medicare drugs. In July, 3 years ago, the Office of Inspector General at the Department of Health and Human Services found that at least 1/3 of the more than 200 manufacturers of Part B drugs had not submitted the average sales price data for some of their products, and an additional 45 manufacturers had not been required to report any data. The Inspector General found that inaccuracies in these average sales price files may affect Medicare payments. Last month, and we've heard that there was a hearing by the subcommittee last month on this issue, on the MedPAC report. MedPAC reported to Congress on Medicare and noted that this problem about average sales price data continues. and that it's not been addressed by this Congress as the Inspector General had recommended. My amendment simply implements the recommendation of MedPAC and the Inspector General to raise the penalty for failing to report the average sales price data that is required by law and ensures that all Part B manufacturers report that data. It simply ensures compliance with longstanding law to protect program integrity and taxpayer interest. Though denied any opportunity really to address price shocks, we ought to at least assure that the data, the information, is available so that responsible authorities always know how big that price shock really is. And with that, Mr. Chairman, I would move adoption of the amendment.
Thank you, Mr. Nunes. You're recognized.
Mr. Chairman, I make a point of order to the amendment because it is not germane to the amendment in the nature of substitute. The amendment violates House Rule 16, Clause 7, because the amendment makes changes to Medicaid, which is outside of the subject matter and beyond the scope of this bill, which only touches Medicare Part B.
Thank you. Does the gentleman offering the amendment wish to speak on the point of order?
I do, Mr. Chairman. I certainly respect your legislative craftsmanship in the way you draw the legislation, in some cases in a very narrow way, to preclude amendments. Certainly that was true in our recent consideration of TANF legislation. In this case, this is Medicare Part B Improvement Act. We have seen what a wide range of legislative aspects of Medicare Part B that this is. It's unfortunate that it was not included from the subcommittee to deal with this very pressing problem. It does not address the soaring prices within Medicare Part B. It only addresses securing data required by current law. It concerns only Medicare Part B. And I believe that it's important that we take this one modest step clearly within the scope of the title of this bill, and I would urge that the point of order not be sustained.
Thank you, Mr. Doggett. I am prepared to rule the amendment is not germane to the amendment in the nature of substitute because it violates House Rule 16, Clause 7, by amending Section 1927 of the Social Security Act, which deals with Medicaid, which is beyond the scope of the bill. Point of order, sustained. The amendment is not in order.
And on that, I would respectfully appeal the ruling of the chair.
The ruling of the chair is appealed. Mr. Nunes moves the table to appeal.
I move the table.
Questions on the motion to table the appeal of the chair's ruling? All those in favor signify by saying aye. Those opposed, no.
No.
Opinion of the chair, the ayes have it. The motion table is agreed to.
Mr. Chairman, on that, I would request a recorded
Roll
vote.
call is requested. The clerk will call the roll.
Mr. Johnson? Mr. Nunes? Mr. Nunes, aye. Mr. Teaberry? Mr. Teaberry, aye. Mr. Reichert? Mr. Reichert, aye. Mr. Roscom? Mr. Roscom, aye. Mr. Buchanan? Mr. Buchanan, aye. Mr. Smith of Nebraska? Mr. Smith, aye. Ms. Jenkins? Ms. Jenkins, aye. Mr. Paulson? Mr. Paulson, aye. Mr. Marchant? Ms. Black? Mr. Reed? Mr. Reed, aye. Mr. Kelly? Mr. Kelly, aye. Mr. Renacci? Mr. Meehan? Ms. Nome? Ms. Nome, aye. Mr. Holding? Mr. Holding, aye. Mr. Smith of Missouri? Mr. Smith, aye. Mr. Rice? Mr. Rice, aye. Mr. Schweikert? Mr. Schweikert, aye. Ms. Walorski? Ms. Walorski, aye. Mr. Curbelo? Mr. Curbelo, aye. Mr. Bishop? Mr. Bishop, aye. Mr. Neal? Mr. Neal, no. Mr. Levin?
No.
Mr. Levin, no. Mr. Lewis?
No.
Mr. Lewis, no. Mr. Doggett?
No.
Mr. Doggett, no. Mr. Thompson? Mr. Thompson, no. Mr. Larson? Mr. Larson, no. Mr. Blumenauer? Mr. Blumenauer, no. Mr. Kind? Mr. Kind, no. Mr. Pascrell? Mr. Pascrell, no. Mr. Crowley? Mr. Crowley, no. Mr. Davis? Mr. Davis, no. Ms. Sanchez? Ms. Sanchez, no. Mr. Higgins? Mr. Higgins, no. Ms. Sewell? Ms. Sewell, no. Ms. Delbene? Ms. Delbene, no. Ms. Chu? Ms. Chu, no. Mr. Johnson? Mr. Marchant? Ms. Black? Ms. Black, aye. Mr. Renacci? Mr. Meehan? Chairman Brady?
Aye.
Chairman Brady, aye.
The clerk will report the vote.
20 yeas, 16 nays.
There will be 20 ayes and 16 noes. The motion table is agreed to. There are additional amendments to the amendment in the nature of substitute. If there are none, the questions on the adoption of the amendment in the nature of substitute. All those in favor signify by saying aye. Those opposed, no. In the opinion of the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Nunes for the purpose of offering a motion.
Mr. Chairman, I move the committee favorably report H.R. 3178 as amended to the House of Representatives.
So the question is on favorably reporting the bill H.R. 3178 as amended. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 3178 as amended is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical conforming changes to bills, and the members have an additional 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business, H.R. 3168, legislation to amend Title 18 of the Social Security Act to provide continued access to specialized Medicare Advantage plans for special needs individuals. I recognize the bill's sponsor, Chairman Teaberry, for purposes of an opening statement.
Thank you, Mr. Chairman. I'm proud that the committee is pursuing this bipartisan effort today. I want to especially thank Ranking Member Levin for co-sponsoring this important piece of legislation with me. The legislation before us is a start of many more bills to come to improve and strengthen our Medicare program. 3168, the Special Needs Plans Reauthorization Act, provides the longest reauthorization of the Medicare SNP, pronounced SNP program, since its creation in 2003, while also improving the quality of care provided to vulnerable seniors and patients living in poverty or with chronic illnesses. Since 2003, SNP enrollment has continued to grow. In 2016, nearly 2.3 million Medicare beneficiaries were enrolled in a SNP. The majority of these enrollees were individuals eligible for both Medicare and Medicaid. This population is commonly referred to as dual eligibles. Dual eligibles are among the highest cost, highest need beneficiaries in both of these important programs. At our hearing in June, the subcommittee examined some of the challenges associated with care coordination and delivery for this population. Witnesses testified that while this varies state to state, the SNP program lacks the necessary coordination of Medicare and Medicaid benefits to best serve the dual population. And we listened, Mr. Chairman. This bipartisan legislation sets the SNP program on a better, more permanent path to integration for the dual population than is currently on today. And it also pushes SNPs to be more outcome-driven when caring for beneficiaries with chronic illnesses who are enrolled in the chronic condition SNPs. In addition to these very important changes, the bill further expands the type of benefit plans that offer to improve health outcome enrollees with chronic illnesses. Included in this bill is Mr. Kelly and Ms. Sewell's legislation, H.R. 3044, a bill that allows Medicare Advantage plans and SNPs to tailor the types of supplemental benefits offered to their enrollees in order to meet the individual needs of patients living with chronic illnesses. As the Medicare population continues to grow, it's important that we look at how we can move from volume to value-based care across all parts of the Medicare program. I want to thank all my colleagues for reaching across the aisle to advance these important Medicare policies. I look forward to continuing to work in this committee and in the subcommittee on additional bills to improve Medicare and advance member priorities that will strengthen the program in the future. Thank you, Mr. Chairman, for your leadership. I yield back.
Thank you, Chairman T. Berry. Now recognize the gentleman from Michigan, Mr. Levin, for purposes of an opening statement.
Thank you, Mr. Chairman, to you and to Mr. Neal, and if I might say so, especially to Mr. T. Berry. It's been, I think, productive to work together and really kind of a pleasure. On June 7, the Health Subcommittee held a constructive hearing on Medicare Advantage with a focus on special needs plans. By the end of the hearing, Mr. T. Berry and I agreed that this was a policy area where we could and should work on a bipartisan solution to increase integration and improve care for Medicare beneficiaries. This legislation moves forward policies to help integrate care for over 2 million of the 11 million Americans who are duly eligible for Medicare and Medicaid. These are among the most vulnerable beneficiaries, as Mr. T. Berry has outlined so well. More than 40% are under 65 with disabilities, and many have very complex health care needs. The special needs plans are the result of past bipartisan interest in providing high-quality care for this population, first as a demonstration and later as an authorized program. Currently, nearly 2.3 million Americans receive coverage through special needs plans, 2.3 million, which are tailored to the needs of specific populations of beneficiaries. These plans are permitted to target enrollment to one or more types of special need individuals, including those who are 1, institutionalized, 2, duly eligible for both Medicare and Medicaid, or 3, living with severe or disabling chronic conditions. The legislation reauthorizes chronic condition special needs plans and dual eligible special needs plans for 5 years, while making permanent institutional special need plans with policy enhancements consistent with recommendations by the Medicare Payment Advisory Commission. The policy aim, as we heard at the hearing and from many stakeholders, is to increase integration of benefits for beneficiaries receiving coverage through both Medicare and Medicaid to improve outcomes. In addition, the bill would allow plans to tailor and expand the type of supplemental benefits offered to meet the individual needs of patients with chronic illnesses. And so I want to thank the sponsors also who've worked on this policy, included in their legislation, H.R. 3044. Let me just close by saying 2 things. You know, sometimes it's asked, why is there national action taken and we simply don't leave it to the states? I think the answer is that at times it takes recognition nationally to spark action that will affect the lives of so many people. And secondly, I want to point out, we've talked about the integration of Medicare and Medicaid, and yet in the last weeks and months, more than $1.4 trillion in cuts to the Medicare program have been proposed. These cuts would jeopardize access to care for the very beneficiaries that special needs plans serve. These cuts would reduce the number of Americans eligible for Medicaid and impose more out-of-pocket expenses for those remaining in the program. This drastic leap backwards in health care for Americans would overshadow the positive steps we are taking today. So while it's been beneficial to work, and I hope we'll continue to work on a bipartisan basis, we also need to look at the failure to have bipartisan support and work on the larger issues facing this population. Thank you.
Thank you. The committee will now proceed to consideration of H.R. 3168. Without objection, the measure will be considered as read and open for amendment at any point. This time, I offer an amendment in the nature of a substitute, which was distributed in advance, along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point, considered base text for purposes of amendment. I'll now turn to Emily Murray, the Staff Director for the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute, with an emphasis on the changes made since introduction. I ask that members hold their questions until after her presentation. Ms. Murray.
Thank you, Mr. Chairman and Ranking Member Neal. H.R. 3168, the Bipartisan Special Needs Plans Reauthorization Act of 2017, was introduced by Health Subcommittee Chairman Teaberry and Ranking Member Levin on July 5, 2017. In general, the legislation reauthorizes Medicare Special Needs Plans, or SNPs, and includes provision to improve quality of care for enrollees. H.R. 3168 reauthorizes chronic condition, or C-SNPs, and dual eligible, or D-SNPs, for 5 years, while making permanent institutional SNPs, with policies to ensure better integration and higher quality performance consistent with the recommendations provided by MedPAC. Specifically, the legislation creates 3 pathways for D-SNPs to increase integration of clinical and financial responsibility for beneficiaries receiving Medicare and Medicaid services, and establishes uniform processes for the dissemination of information, as well as grievances and appeals. This legislation also improves the quality of C-SNPs through new care management requirements, such as specialized interdisciplinary team, annual face-to-face encounters, and a specialized model of care, as well as establishing a panel of clinical advisors to develop a list of chronic conditions that can qualify for such plans. Finally, H.R. 3168 includes legislation introduced by Mr. Meehan and Ms. Sewell to allow plans to provide meaningful supplemental benefits tailored to specific patients' needs. As noted on the green sheet, the Chairman's amendment would move up the date required for dual SNP integration from 2022 to 2021. The amendment would also provide additional guidance and flexibility for how plans can qualify as integrated dual SNPs if they don't qualify as either a fully integrated dual eligible SNP, or their state does not allow for or require a plan to enter into a capitated contract with the state Medicaid agency to provide long-term services and supports or behavioral health services. This would allow the Secretary, in consultation with stakeholders, to determine other appropriate types of integration arrangements, providing flexibility to plans while respecting state laws. Mr. Chairman, that completes my walkthrough. I'm happy to answer any questions.
Thank you, Ms. Murray. Are there any questions for the amendment in the nature of substitute? Mr. Teaberry, you're recognized.
Mr. Chairman, on behalf of the members of the subcommittee, I want to thank the staff, Emily Murray and her team, who worked closely with the Democrat staff for weeks, months, years in some cases on this healthcare legislation. They've done a fabulous job and have been very professional. Also like to thank my personal staff, Whitney Daffner and Abby Finn.
Thank you, Mr. Teaberry. Ms. Sewell, you're recognized to ask any questions about the amendment in the nature of substitute.
Actually, I wanted to strike the last word. So.
I think we're going to get there in just a second. Does anyone wish to strike the last word? Ms. Sewell, you're recognized.
Thank you, Mr. Chairman. Mr. Chairman and Ranking Member Neal, thank you for holding today's markup and giving us an opportunity to advance bipartisan bills aimed at improving the Medicare program for the millions of Americans who rely on it for their health care. Medicare Advantage helps reduce costs for those with chronic conditions and provides patients with the resources needed to improve their health. The changes we are proposing today will enhance delivery of high-quality care, improve patient outcomes, and reduce overall costs to the system. H.R. 3168 includes a bill I was honored to introduce with Congressman Meehan from Pennsylvania, H.R. 3044, which allows plans to tailor and expand the type of supplemental benefits offered to meet the individual needs of patients with chronic illness. Under our bill, traditional Medicare Advantage plans and special needs plans will be able to offer individualized benefits to chronically ill enrollees. This also includes services that have a reasonable expectation of improving or maintaining the health or overall function of the chronically ill enrollee. For example, nutrition services, counseling and in-home supportive services, and transportation services are all now included. In districts like mine with a high rural, elderly, and low-income population, these services can go a long way in reducing costs and improving access to care. Unaddressed, non-health related issues exacerbate chronic illness for elderly and low-income Americans like the ones that I represent. During our last Medicare markup, I spoke about Miss Eva. Miss Eva, a rural elderly constituent of mine from my hometown of Selma, Alabama, has multiple severe chronic illnesses, including diabetes. Like many rural Americans, Miss Eva has limited transportation options and cannot afford in-home support services, counseling, and other non-medical services that would improve her overall outcomes. Her lack of transportation often leads to missed primary care appointments, which ends up costing more by making her go to the emergency room to receive care. Even when care is readily available, many Americans struggle to find reasonable transportation. The University of Alabama at Birmingham is home to some of the leading healthcare providers in the country, but it doesn't matter if my constituents live in rural Black Belt, Alabama, and have no way of getting to Birmingham or no access or limited access to ambulances to get them there. For some, even getting across their small rural town to visit their doctor is a feat. This misappointment doesn't get their medications refilled or ultimately end up in the emergency room. This is really unsustainable. So under our bill, Ms. Eva would have access to transportation through her plan and would not have to take an ambulance when she doesn't have someone to take her to the pharmacy to get her insulin or to a doctor's appointment for her diabetes maintenance. She could have access to in-home support services and nutrition assistance, among other services. All of these would undoubtedly improve Ms. Eva's life and save costs. If we want to make the most of our Medicare dollars, we cannot view the delivery of health care in a vacuum. We must address all of the factors that contribute to costly chronic illness for our constituents. I want to thank Congressman Meehan for working with me on this important legislation, and I urge all of my colleagues to support the underlying bill. Thank you, but I yield back the rest of my time.
Thank you, Ms. Sewell. Does anyone else wish to strike the last word? Mr. Meehan, you're recognized. Can you check that microphone, Mr. Meehan?
Okay, I think I got it. Thank you, Mr. Chairman, and I want to also thank Chairman Tiberi and Ranking Member Levin for the work to reauthorize the Special Needs Plan and support the efforts to improve access to supplemental benefits for chronically ill seniors, and for including within their legislation, 3168, a bill that I was pleased to work on in a bipartisan fashion with my colleague, Congresswoman Sewell. This reauthorization bill includes legislation that we reintroduced to allow individuals with chronic illnesses to receive additional unique benefits through their Medicare Advantage plans. In other words, it will remove the uniformity requirements of Medicare Advantage plans for these chronically ill enrollees. Americans with 5 or more chronic conditions comprise 12% of the United States population, but they account for 41% of all healthcare spending. These are the kinds of things that we could begin to work on to actually have an impact, not just on increasing quality of care, but also in decreasing costs. CMS data show that 18 of the 19 most common chronic conditions are more prevalent in my town among Pennsylvania Medicare enrollees compared to all Medicare enrollees nationally. And seniors with chronic conditions such as diabetes, hypertension, and dementia are more likely to visit an emergency room and require hospitalization. H.R. 34 ensures that the MA plans and providers can offer personalized care for seniors with complex health care needs. These additional benefits could include transportation to doctor's appointments, as my colleague Congresswoman Sewell pointed out, but also, very importantly, include home care. I'm just feel very privileged to be married to a nurse who delivers home care and can tell you what a difference it can make for a chronically ill senior to have the advantage of care delivered in their own home. Oftentimes, one of the few times they feel that they really can concentrate on understanding the nature of the care before them, and they frequently do much better in their own home situation. The value of providing additional care and services to chronically ill seniors is the avoiding of costly hospitalizations and emergency room visits and improved health outcomes. I appreciate the support for this effort, appreciate the ability to work in a bipartisan fashion with my colleague, Ms. Sewell, and appreciate the support of the committee on this important legislation. Mr. Chairman, I yield back.
Thank you, Mr. Meehan. Mr. Levin, you're recognized. Sure, and we'll get to her.
I just wanted to thank Mr. Meehan and Ms. Sewell, but also to pick up what Mr. Tiberi said about the work of the staff, which is behind us on both sides. It really took some considerable time and effort to perfect these bills. It really did. It involved many meetings to go over them. And so the fact there's bipartisanship, I think we need to indicate that much of that important work with the spirit set by us was done by the staff. Thank you.
Thank you, Mr. Levin. You're so correct. Ms. Sanchez, you recognize to strike the last word.
Thank you, Mr. Chairman. I have to say it is nice to come to work on a bipartisan policy that helps some of our sickest and frailest beneficiaries. With that said, I want to thank Representatives Tiberi and Levin for working together to bring this package before the committee. Special needs plans are an essential part of how we care for those seniors that require a little more help. And although it's encouraging to see the committee see the value in these plans, I was hoping that the committee would permanently reauthorize the SNPs. Unfortunately, we know that long-term planning in health care can often be a fool's errand. A beneficiary's health can take a sudden turn for the worse, even with the best of plans. This is especially true for those people who suffer from diabetes, ESRD, HIV/AIDS, and chronic and disabling mental health conditions. Given the uncertainty surrounding chronic medical conditions, it's my belief that policymakers should be providing certainty to plans and providers so they can focus on managing the health of a beneficiary. And while I'm glad that the committee could get to a 5-year reauthorization, I feel that a permanent reauthorization would have done more to help. I'd also briefly like to bring attention to legislation that Representative Meehan and I have been working on for a few years now to deliver community-based services to keep individuals healthy without reducing their meager assets. Some beneficiaries require the long-term care traditionally provided by Medicaid, but their relatively limited financial means makes them ineligible for such services. Unfortunately, there is nothing in current law that would prevent them from racing into poverty in order to receive these services. Our bill would establish a new community-based institutional special needs plan demonstration program to help our seniors avoid the dreaded Medicaid spend down while allowing them to receive long-term supports and services in their home without being institutionalized. Mr. Meehan and I remain committed to working on this, and we look forward to working to make this a reality. I want to thank committee staffers Alyssa Polisi and Melanie Ergoin for working with my staff and Representative Meehan's staff on our CBI SNP bill. And with that, I yield back my time.
Thank you, Mrs. Sanchez. Does anyone wish to strike the last word? I'd like to ask unanimous consent to submit the record number of letters in support of the legislation. Are there any amendments to amendment in the nature of a substitute? If there are no amendments, questions on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Those opposed, no. In the opinion of the chair, the ayes have it. The amendment made substitute is agreed to. I'll now recognize Mr. Tiberi for the purposes of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 3168 as amended to the House of Representatives.
The question is on favorably reporting the bill. H.R. 3168 is amended. All those in favor signify by saying aye. Aye. Those opposed, no. In the opinion of the chair, the ayes have it. The motion is agreed to, and H.R. 3168 is amended. Is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill. The members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next and final order of business, H.R. 1843, the Clyde Hirsch Sowers Respect Act. And I recognize the bill's sponsor, Chairman Roskin, for purposes of an opening statement.
Thank you, Mr. Chairman. I ask unanimous consent to insert in the record supportive letters from National Taxpayers Union and Americans for Tax Reform.
Without objection.
Mr. Chairman, thank you very much for the opportunity to mark up H.R. 1843, the Clyde Hirsch Sowers Respect Act, which puts an end to an improper use of civil asset forfeiture by the Internal Revenue Service. Here's a quick background. If a person deposits $10,000 or more into a financial institution, that institution must submit a currency transaction report to the Treasury Department. Avoiding this reporting requirement by purposefully staying below the $10,000 limit is a federal crime known as structuring. Structuring was made illegal in 1986 to prevent large-scale criminal enterprises, terrorists, and money launderers from hiding their money from authorities by consistently depositing just shy of that $10,000 limit. When structuring is believed to have occurred, the IRS can use its civil asset forfeiture authority to seize funds and force the owner of the funds to prove that they were obtained legally. So far, so good. We can all agree that terrorists and criminals shouldn't have access to illegally obtained money. And if the IRS had used its civil asset forfeiture authority solely to disrupt criminal enterprises, we wouldn't be marking up this bill. But of course, that's not what happened, and this is a problem we've got to solve. Let me tell you about someone who had their money seized by the IRS. Andrew Clyde, who served 3 combat tours in Iraq, came home, opened a store in Georgia. Mr. Clyde had an insurance policy that only covered up to $10,000 in off-premises losses. So, at the end of the business day, he regularly deposited less than $10,000, of course, because his policy only covered $10 grand. For that reason, the IRS seized $950,000 from him. The agency then threatened him with criminal structuring charges until he agreed to settle and forfeit $50,000 to the IRS. That was after he spent nearly $100,000 in legal fees. Despite no underlying criminal activity, Mr. Clyde lost almost $150,000. In February of 2015, the Oversight Subcommittee examined these practices by the IRS, and I have never seen such a display of bipartisan outrage before. This practice was so inherently wrong that no one rose to the defense of the Internal Revenue Service, and I'd like to particularly thank the ranking member, Mr. Lewis, and Mr. Crowley, the lead sponsor of this legislation. Together, we've been fighting this battle for almost 2.5 years. In that time, we've had some wins. IRS Commissioner Koskinen apologized to the victims of this practice on behalf of his agency. In fact, a year later, he even changed IRS procedures to restrict the use of civil asset forfeiture cases in which the money was earned illegally, a common sense decision that we hope to codify with this legislation. And I'm also heartened to say that in March of this year, the IRS finished its process of reviewing all 454 contested cases that occurred before the rule. The agency either returned or recommended that the Department of Justice return approximately 80% of the funds. The IRS themselves returned over $6 million to honest Americans who were victims of this government outreach. One such case, which ended in the seizure of returned funds, was Randy and Karen Sowers, dairy farmers from Maryland, who served as one of the namesakes of the legislation we're considering today. And while the IRS returned over $6 million in seized funds, they've also recommended to the Department of Justice they return a whopping $16 million. And this is where the case takes a darker turn. The Department of Justice has a long, did I say long, way to go in tackling the backlog of undecided cases. In May of this year, Congressman Lewis and I wrote to the Attorney General inquiring of how many cases had been reviewed by the agency. Acting Assistant Attorney General Samuel Raymer informed me that while the IRS had already finished reviewing all 454 petitions, referring 250 of them to the Department of Justice, the Department of Justice had only made decisions on 73 of them. Furthermore, the Department of Justice only approved the return funds of 32% of the cases, well below the 80% that the IRS had recommended. One of the cases in limbo is that of Andrew Clyde that I previously mentioned. This is not good enough. I'll be following up with the department to request a fuller explanation about the remaining 181 taxpayers who've yet to receive a response as to where their money is. If there's justifiable reason for the United States government to keep their money, then so be it. Let's hear it, and let's hear it in public. But this practice of dragging these cases out for years is outrageous. Mr. Lewis, I hope that you will accept an invitation to me and join in a letter to that end. Americans deserve a government that they can trust, Mr. Chairman. I look forward to working with my colleagues to pass this legislation, and I encourage a favorable reporting. I yield back.
Thank you, Mr. Roscoe. I'll recognize the gentleman from New York, Mr. Crowley, for purposes of an opening statement.
I thank the gentleman for yielding me. I'm getting goosebumps for all this bipartisanship. It's great, Mr. Chairman. Thank you very much. Today is a good day for the American taxpayer, as shortly this committee will pass the Clyde Hirsch Sowers Respect Act to enact vital reforms to the federal government's civil assets forfeiture process. Civil assets forfeiture is an important tool. I think both Democrats and Republicans recognize that the IRS and other federal agencies use to go after ill-gotten gains from drug dealers, from human traffickers, terrorists, and other high criminal activity. As the son of a New York City police detective, I would never want to weaken that vital law enforcement tool. But this legislation will codify into law much-needed reforms to the process to stop abusive asset seizures, such as the ability of the government to seize a person's bank account without ever charging them with a crime to begin with. The Oversight Committee undertook a painstaking 2-year investigation, which included holding a series of congressional hearings, meeting with officials from a number of federal agencies, and continually keeping the pressure on the IRS to proactively contact and return any assets seized from people who were never charged with any criminal activity. These actions culminated in this bipartisan legislation that Mr. Roscoe, and I congratulate you, sir, for your persistence, and I are bringing before the committee today, which aim to take what we have learned and fix the system to prevent the seizures of bank accounts of law-abiding citizens. Specifically, this legislation prohibits the IRS from undertaking any civil asset forfeiture related to structuring unless the funds are from an illegal source or the funds were structured to conceal other criminal activity. Additionally, to provide due process to affected taxpayers, the bill requires the IRS to notify an account holder of a seizure within 30 days of that seizure, and it allows the person whose assets were seized to seek a post-seizure hearing within 30 days of the notice of the seizure by the court. That's all in keeping with timing and allow for due process and justice to be heard. We know that those engaged in illegal actions will usually not contest the seizure, but for those who committed no crimes, this bill levels the playing field by mandating the return of any seized bank accounts or other assets if the government can't prove the seized funds were derived from an illegal source. Passage of this bill isn't the last part of this fight. This committee passed this bill last year, 53 weeks ago exactly, this week. The House of Representatives passed this bill on a unanimous vote of 415-0 in 2016. We need to pass this bill again here in the House and the Senate to get this bill signed into law. But even as we work for a swift passage of this bill into law, we will continue to keep the pressure on the federal government to quickly return the assets of those innocent taxpayers not charged with any crimes, whose assets are still being held by this government. I look forward to the passage of this bill today and correcting this wrong in our law. And with that, once again, thank Mr. Roscoe for his bipartisan spirit in this effort to change this wrong. And I yield back my time and urge a swift passage of this common sense bill.
Thank you, Mr. Crowley. The committee will now proceed to consideration of H.R. 1843. Without objection, the measure will be considered as read and open for amendment at any point. This time I offer an amendment in the nature of substitute, which was distributed in advance along with the green sheet explaining it. Without objection, the amendment in the nature of substitute shall be considered as read, open for amendment at any point, considered base text for purpose of amendment. I'll now turn to Tom Bartold, the Chief of Staff for the Joint Committee on Taxation, to provide the technical description of the amendment in the nature of substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation. Mr. Bartold, you're recognized.
Thank you, Mr. Chairman. Members of the committee, you have before you two joint committee documents, JCX 33 and JCX 34, which describe the present law relating to asset seizures in relation to structuring of financial payments, and H.R. 1843 as amended by the Chairman's amendment, the nature of a substitute. This legislation does three things. It codifies present practice, requiring that property may be seized only if it is established that it is derived from an illegal source or that the structuring was done for the purpose of concealing a violation of criminal law. It provides notice of seizure to the owner of the property, and as noted by Mr. Crowley, notice to the recipient that they may request a court hearing. And lastly, it excludes from gross income for purposes of the federal income tax any interest paid by the federal government related to property when the property is returned to the individual whose property was seized. These provisions would all be effective upon the date of enactment. That concludes my brief description of the legislation before you. Be happy to answer any questions that the members might have.
Thank you, Mr. Bartold. Are there any questions about the amendment in the nature of a substitute? Does anyone wish to strike the last word? Are there any amendments to the amendment in the nature of a substitute? If there are no amendments, questions on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed, no. Opinion of the chair, the ayes have it. The amendment in the nature of substitute is agreed to. I'll now recognize Mr. Teaberry for the purposes of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 1843 as amended to the House of Representatives.
The question is on favorably reporting the bill, H.R. 1843 is amended. All those in favor signify by saying aye. Aye. Those opposed, no. Being the chair, the ayes have it. The motion is agreed to, and H.R. 1843 is amended, is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to the bill, and the members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. I want to add my congratulations to the bipartisan work that's been done on this legislation. There being no further business for the committee stands adjourned.
Good job, guys. Did he smile? Richie, did he smile? There it is.